Unfortunately, 80% of the patients that come to us with pancreas cancer come with metastatic disease. And so it used to be that we would quote patients, 4-6 months average survival once they were diagnosed with metastatic disease. But certainly now we have new chemotherapy combinations, new chemotherapy options that are maybe extending that survival to maybe even 10 to 12 months if we're looking with our rose-colored glasses. Tony, tell us a little bit about some of these combinations and what do you do in this setting?
So it's definitely has shifted, at least since 2010, to a little bit more positive. We're not quite there yet, but I think as we understand a little bit more how to divvy up pancreas cancer into subgroups, we will continue advancing that. But today, very simply, we have two standard regimens for patients who are relatively well performant. I mean, those patients who have performance status 0 to 1 are those that seem to benefit the most from chemo, 2 borderline. I know we'll discuss this a little bit more, but clearly for most of our patients who are eligible for treatment, there are two regimens. One is a 3-drug regimen, the other one is a 2-drug regimen. 3-drug regimen FOLFIRINOX, then gemcitabine, nab-paclitaxel. And the question is, how do you pick between the two? You have this patient coming to your clinic and you have to make that decision. They've never really been compared head to head. We make all the assumptions that 3-drug is probably better because essentially the data looks a little bit better historically. Although, there's a lot of biases that get introduced into these types of cross-study analyses. The reality is, in the real world, when we look at a lot of the databases and the more recent studies, they look kind of similar in terms of their outcomes. The key is to think now more about how do we allow patients to get exposed like we do with colon cancer, lung cancer, and others, although we're limited in the choices here. How can we expose patients to perhaps or think about sequencing rather than to throw the whole gauntlet? So in my practice, for most patients, the first line is going to be gemcitabine and nab-paclitaxel, thinking about potentially a second line option with 5-FU, Naliri, or nanoliposomal irinotecan. FOLFIRINOX, in all frankness, I've used it very selectively, either on trials or for those patients where I suspect perhaps some element of BRCA or BRCA-NS, where we know irinotecan and oxaliplatin both have significant activity, taxanes or gemcitabine don't. So for that, which amounts to about 5 to 10% of patients, perhaps FOLFIRINOX is a better choice. But for the others, frankly, I don't see much of a difference between the two. In fact, my preference has been to be, I would call it, a little bit more merciful on my patients and essentially, think sequentially rather than, throw the whole kitchen sink on them.
Now, I always find this fun to query medical oncologists, especially GI oncology specialists, which they believe in, because I find that it's when you have your regimen, it tends to be a very passionate belief. So I'm gonna perform my experiment here. So Thomas, FOLFIRINOX or GemNab?
Well, we would probably use a little bit more FOLFIRINOX. It's about 30% FOLFIRINOX, 70% gemnab-paclitaxel in those who can receive active chemotherapy in first line. We've made good experience with FOLFIRINOX, and there are some patients who really tolerate it well. Problem is predictability. We had young patients who actually couldn't stand it and had very serious side effects, and we had more elderly patients who had no problems at all. So it's very hard to predict who is going to do well. Whereas with gemnab-paclitaxel, usually there is a much broader tolerance, and we didn't see these extremes we've seen with FOLFIRINOX. But we have around about 30 to 70%. This is the ratio we use it.
So tell me, do you modify the FOLFIRINOX at all?
Well, we do in a way that we do not use the bolus, and we de-escalate after, let's say, 3 to 4 months of treatment and take out the oxaliplatin. And that works well in our hands.
Very good. Now, do you use growth factor support?
Well, if required, yes. And as in the Quanura trial, we probably 30% will definitely need it. We don't do it automatically, but we are, particularly in the elderly population, very cautious, and in that case, we also would use it in a preventive basis.
Good, so I don't feel so wimpy anymore. Very good, very good. Ramesh, what's your choice?
I think it's about similar. Obviously, in the Mayo system, there are differences even there.
Okay. Glad to hear that.
Here, see, well, you guys just...
there's Arizona, Rochester, and Florida, and we have some regional, and intrastate differences. But
Is it the cold weather? Do you think that's what made
But I think I tend to use about 20 to 30% modified FOLFIRINOX without the bolus, Gem/Abraxane in 60%, and maybe 10-15% single agent Gem. And the FOLFIRINOX is obviously modified, no bolus. A lot of times I will dose reduce the irinotecan and oxaliplatin by 20%.
Good. Winson, the Canadians. Yeah, I don't know.
Right. Well, it's an interesting question because in Canada we have very strong population-based data. So 2-3 years ago when GemNab first became available, we looked at our experience, and it was a 50-50 split actually between FOLFIRINOX and GemNab, with a very small minority using Gem monotherapy. And we recently re-looked at the same data, or a new cohort of data, and the tides are really shifting. The breakdown now is more about 60% GemNab and 40% FOLFIRINOX. But to others' points, for FOLFIRINOX, there's a huge tendency to also dose reduce and modify FOLFIRINOX. So it kind of calls into question whether we're still really giving the same benefit when we're really modifying it to the nth degree.
That's a great question. Actually, I'm gonna throw the vote now to Manuel, but I'm going to ask you a question about dose modification because you were so involved in the original studies with GemNab paclitaxel. But let's start with. So let's see if you.
So I think in the U.S. The trend is GA, gemcitabine Abraxane, is probably 60%, 70% of utilization now. If you ask me what happens at the Harvard Cancer Center, I'll say that most people use FOLFIRINOX for the patient who is fit, with the different modifications, and we have discussed the key ones. I personally use more gemcitabine Abraxane, and what I find very interesting is that if you look at the last studies, mostly single center experiences, retrospective studies, but also the control arms of randomized clinical trials in which patients were highly selected. GA is giving you the same 11, 12 months median survival as FOLFIRINOX. So I personally think that the MPACT trial, it was loaded perhaps with the patients that had a lower performance status than what is
or no second-line options too. Yeah. A lot of the countries didn't have options. And to that point, and I would like to second that, is that there was a recent publication from the U.S. Oncology database that looked at their experience with both gemcitabine, Abraxane, and FOLFIRINOX in terms of utilization, in terms of outcomes. And intriguingly, they found the same trends. Is regardless, patients do about the same in terms of their survival and outcomes, whether you choose FOLFIRINOX or gemcitabine Abraxane. So I concur 100%. I don't really think that there is much of a difference as long as you have access to salvage second-line therapies. And so a sequential approach is actually what we do in all other cancers, except in this one we tend to believe that maybe we shouldn't.